shall now go on to the next speaker, Dr. RITIKA SACHDEV, again, a senior consultant and actually an additional director, the medical services at the Center for Sight Group of Hospital, who's a cataract, cornea, and refractive surgery as a specialty, and is doing an amazing work when you see the wonderful growth of Center for Sight as a whole over the entire country. And she is going to take us on to intracorneal ring segments, current indications and techniques. So let's hear from her.
Thank you, Dr. Chitra, for this opportunity. I'll be talking about our experience with intracorneal ring segments. These are basically tiny arcs of PMMA which are implanted in the cornea. They were originally designed to flatten the cornea to treat myopia, but there, of course, the excimer laser did a fabulous job. And because this was a tissue additive technique, its use got translated to corneal ectasia, wherein you are dealing with a weaker cornea and you would prefer not to subtract tissue, but to add to the tissue. So various ICRS segments are available. The intact segment is what we have used frequently. Now, of course, you have biotech coming up with its own segment. You have the Ferrera rings, the Kera ring segments. The things to remember about these segments is that they vary in thickness and in cross section and in the place at which they are implanted in the cornea. The closer they are to the pupil, the more effect of flattening they will induce, but also then they will have unwanted photic phenomena, which is taken care of by choosing an appropriate cross section to minimize the glare and other such side effects. The thicker they are, again, the more will be the effect. So the thickness and the area of implantation and the cross section are important criteria which you should review depending on the segment that you are looking at. These segments basically work in spacer devices. Now you can see when you put in a spacer device, you're basically shortening the arc and therefore flattening the center. This cone obviously is a bulging area and flattening it will functionally improve the vision. But where the ICRS segment score additionally is that there is a stress or a biomechanical stress that is induced in the cornea, which leads to progression of these cones. What the ICRS segment does is that it redistributes the stress, and therefore, in cases such as post-Lasik ectasia or in cases where you feel that the keratoconus is progressing despite cross-linking, this is an additional tool because it will redistribute the stress forces and possibly has a role in delaying the progression of keratoconus also, in addition to the functional benefit that it will provide by flattening the cornea. Now, these are the indications that we use in our practice. I feel this technique works very well for patients who are contact lens intolerant or who have ectasia in one eye because they see well with the other eye and therefore do not have the inclination to continue wearing contact lenses just for improving one eye. Contact lens fitting after ICRS is a little tricky, though some people feel it's not. In my practical experience, it is tricky. So if a person is doing well with contact lenses, I would not venture in for ICRS so easily. The patient should have a central clear cornea and a good thickness at the site of proposed incision, that is at whatever zone that you are implanting, which may be different for different ICRS. 450 was the cutoff for ICRS of intacts, but various other rings may have different cutoffs. And obviously, you are sparing this patient from a corneal transplantation option. The plan requires you to do a good topography and based topography preferably, and also do a good refraction. We try to base the planning on refraction more than topography if the refraction is reliable. That means the steep axis is defined basis the refraction. If the refraction is reliable, if you feel the refraction is not as reliable in case of poorer vision, then you go on to the topography map. Please note that, like has been mentioned earlier, this is a good modality for eccentric cones and for moderate cones. If a patient has vision of 6/9 or better, ICRS is best avoided because it is not fully mathematical. It is more an art than a science, and patients with vision better than 6/9 may lose vision also. Now let's plan the ICRS segment. Refraction is important because more is the bulge or more is the refractive error, the more is the flattening you want to do, and therefore you use a thicker segment. Like Sahil pointed out, for eccentric cones, that means which are where the posterior float is outside the 3 to 5 mm zone, there you will need asymmetric or single segments. And for more central cones, you will flatten it diffusely. You don't want one-sided, lopsided treatment for a symmetric cone. So you're going to use a symmetric or two equal segment for this central cone. The incision is planned on the steep axis, like I said, which should be defined by refraction. If refraction is variable, then go on the basis of topography. We use the femtosecond channel to create these channels into which the ICRS is inserted. This is an example. The patient has keratoconus, and this is the refraction -1.5 sphere with a -3.75 cylinder. Remember, the refraction has to be transposed to a positive cylindrical form. And then if the cylinder is more, you're more likely to deal with an eccentric or an asymmetric segment requirement. And if the sphere is more, it is more likely a symmetric segment requirement. Right? So here, once we transpose, if the sphere is more, so we are going in for symmetric segments, the thickness of which depends on the quantity of flattening or the spherical equivalent. And this is the patient post-operatively. And this is the difference map, which shows an improvement in topography, refraction, and BCVA. Similar case of KC, but this is again an eccentric cone. And you have a cylindrical component, which is much higher than the spherical component. Therefore, either you go in for a single segment or asymmetric segment with a thicker segment in the area where the cone is larger, that is the inferior segment, most commonly being thicker. This is the patient and the difference map, which shows an improvement up to 6.6 also. We normally combine the ICRS with cross-linking because we do it in a simultaneous sitting. It gives you a single stage procedure. It also allows increased cross-linking of the channel because the riboflavin pulls in the channel, and the cross-linking of the channel is supposed to enhance the effect of the ICRS. You may, however, do the ICRS first and the cross-linking later also, but not the reverse way. Because once you are regularizing the cornea with the ICRS, it is post that you would want to freeze it with the CXL procedure. This is a patient who had simultaneous CXL and ICRS. This is the post-operative outcome. You see that the astigmatism has fallen from 5.4 to 1.1. So the results are often very gratifying. This is another case where you see this is the post-Lasik ectasia. This is a case which does not respond very well to CXL at times because the Lasik flap getting cross-linked, possibly the anterior effect of cross-linking is more, and therefore the end result of cross-linking in post-Lasik ectasia is less than that in keratoconus. And here the ICRS is a very useful tool, and we do ICRS in most of our post-Lasik ectasia cases. And this is the improvement in vision. Like with any procedure, it does come with a share of complications. However, the cornea is a very forgiving tissue. This is a patient of ICRS where there is a white cell reaction. So there is some dead space around.
You have 1 minute remaining, ma'am.
So this is a white cell reaction. Do note that around the tunnel, you sometimes have lipid and calcium deposits also, but white cell reaction will be accompanied by symptoms and congestion. And this is important to treat with steroids because this prevents an extrusion or a melt of the cornea. This is a patient who's had a melt after many years of ICRS. You avoid a melt by making sure that the proximal segment is at least a millimeter inside the incision. We also suture the incision and remove the suture after about a month. But in case it is extruding, you have no option but to remove the ICRS in such a case to prevent further melting because it sets in a vicious circle of melting. The epithelialization doesn't happen over the PMMA segment. So this the segment has been removed after many years. Fortunately, the flattening persisted because the cornea had remodeled and there was scarring around the tunnel, and that possibly led to a perennial effect of flattening and remodeling. So this is a very rare case of a femtosecond assisted channel led to a perforation, but again, you simply remove the ICRS and the cornea, being a forgiving tissue, recovers back very well. So all in all, I'd like to conclude by saying that ICRS, being a tissue additive technique, is a predictable option for functional improvement in patients with corneal ectasia. We recommend it as a simultaneous single procedure along with CXL. Complications, though, are few, but they are very easily manageable, and patients are often very happy with this if chosen for the right case. Thank you for your attention.
That was a wonderful talk, Ritika. So before I take the question of the expert panel, I'm going to ask you a question. Do you feel the intacs being placed in a post-cross-linked eye at a later date, how effective it has been in your hands?
It is definitely less effective post cross-linking, and actually the perforation that we had was also post cross-linking, because we don't know whether the haze altered the femtosecond pass or not. So we had this consideration of the femtosecond laser channel also being tougher to create, the insertion becoming tougher, and don't know whether the perforation was related to that. So the intraoperative section may also be tougher in certain cases, but usually cross-linking is in the anterior part and the channel is posterior. So I personally have not had much trouble inserting it post cross-linking. However, the effect is less. So I would opt for a thicker segment post cross-linking.
Dr. Praveen, I have this question for you. What is your cutoff when you would use a single segment and when would you use asymmetric segment? And
even before answering that question, I think my tolerance for intacs has gone up quite a bit. So now I prefer that if somebody is suitable for TPRK with cross-linking, I would prefer to do that, because I think you would control the result more or more accurately than with intacs. Intacs is a bit of a hit and miss in some cases, and great talk, Ritika, and you'll sort of agree with me as well.
Yes.
But again, from the perspective of whether to sway in the intacs direction or TPRK, again, those corneas that have more asymmetry, I don't think I put a number to it or a value to it, will benefit more from intacs as compared to those who have symmetrical cones.
yeah.
So symmetrical cones probably more TPRK or just PRK by itself, whereas asymmetric cones intact followed by cross-linking.
Yeah, I think also if it's a more of a localized astigmatism, then the single segment, and if it has got associated with a spherical equivalent being higher, then I think asymmetric segment could also be thought of. Though I think largely we seem to be doing more of single segments now with a very significantly good result. I'm sure that must be the same all over.
I think intacs has found a lot of flavor in post-Lasik ectasia in everyone's hands, because there it is a very useful tool. Cross-linking is less effective, and in post-Lasik ectasia, most of us are actually doing single segment because it's an inferior ectasia, and that remains a very common indication for ICRS.
Yes,
Radhika? Yeah, that was an amazing presentation, Dr. Ritika. I think it's one in which you power packed all the points in such a short time. Truly we went through the gamut of how to select, what to select, and what to expect. So the only question I have for you before moving on is that we know that many keratoconus patients have a background of allergy. We won't do any of these procedures unless allergy is under control, because then we could have recovery or healing issues. So if a patient has a background of Corneal, would that affect your decision of doing intacs? Do you think that the complications that you showed earlier, like inflammatory cells or white cells, or even a melt over the intact, may be influenced by taking in a patient with a background of Corneal catarrh?
Absolutely, I think it's something very important. Even for cross-linking, we see sterile infiltrates more. The risk of progression even in cross-linking. So I treat VKC before any procedure. For intacs, not only does the VKC increase the risk of corneal melt by itself, the eye rubbing itself also is predisposes to a melt. So both are very important. You want to treat the symptoms and the inflammation both significantly. And the white cell reactions that we see are more common in younger individuals who have VKC, and these are the ones which later lead to corneal melt. So we definitely we look out for the ocular surface both before cross-linking and after before ICRS.
So that's the message I wanted the PGs who are listening to get, that not to just get carried away by the maps and the surgery and the glorious result, but most of the hard work lies in selecting and preparing the patient for these procedures, which then defines the outcome. Thank you so much. You put it across it again.
We shall now go on to our next speaker. Thanks a lot, Ritika. That was amazing.